Good evening, everyone. My name is Paul Reed, and I'm the General Manager at the Institute of Sport, Exercise and Health here in London. The ICH provides excellence in sports performance, injury prevention and management, whilst bridging the gap between elite and amateur sport. We're also a centre of excellence for exercise prescription for the improvement of population health. Thank you very much for joining us this evening for what is our 7th webinar in the 2021 series. For more information about our clinical services or to view the previous recordings from this year, please visit our website at www.ich.co.uk. So tonight, the focus is on all things shoulder instability, and I'm delighted to be joined by a team of experts who combined have years of experience in the field of shoulder injuries. We have 4 fantastic presentations for you, and this will be followed by an interactive question and answer session and during the last part of the session. Throughout, please feel free to post questions which the speakers will get to during the Q&A, and this will allow us to have a really interactive session towards the end. Please also feel free to share any content that you wish on social media, and the Twitter handle for that is @theICH, and this will allow us to achieve a broader reach and share the fantastic content with the rest of the community. So without further ado, let's move on to our first talk of this evening. And our first speaker is Mr. Carlos Cobiella. Mr. Cobiella is a consultant orthopedic surgeon at University College Hospital and an honorary lecturer at University College London. He is the head of the upper limb section at the Institute of Sport, Exercise and Health, the NFL upper limb surgeon in Europe, and the shoulder surgeon for London Underground. He works with a wide range of both elite athletes and amateur athletes and anybody that will come across any aspects of shoulder injury, and he continues to publish widely in scientific journals within the field. So without further ado, over to you, Carlos.
Good evening. On behalf of the shoulder practice, I would like to thank you for being here tonight with us in this event about talking about instability. I'd like to thank the Institute of Sport, Exercise and Health for organizing and facilitating it. And without further ado, let's talk about the management of traumatic instability. This is the beast we are involved with. We're talking about that we call a joint. In actual fact, it's a combination of joints. Tonight we'll be talking mostly about exclusively about the glenohumeral joint. And to give a bit of background, the stabilizing mechanisms of the shoulder can be passive or active. The passive ones are mostly the labrum, although the bumper effect is greatly overrated, and the capsule, and in particular the thickenings of the capsule we call glenohumeral ligaments, which act as check reins in different positions of the shoulder. The active ones are very importantly proprioception, and that allows us to understand where our shoulder is and the muscles to improve the neuromuscular control, the balance of the cuff that will keep the head centered. In terms of how we classify it, I tend to think about them in these groups. The largest one of them would be the traumatic structural, followed by atraumatic structural. The type 3s, thankfully, are muscle patterning disorders that they're very rare, and those are the ones that generally are dealt with by physiotherapists, as surgically we shouldn't be contributing. And let's talk about type 1s. Type 1s are the ones that happen in a normal shoulder when there's a force applied that exceeds the tolerance of the capsule and the ligaments. This is a very common position for dislocation, abduction and external rotation, and when it's forced, you do get a dislocation, an anterior dislocation. And that results in this type of X-ray, which actually it doesn't look too bad. It looks as if it slipped slightly out of the joint, but in fact, the damage that happens is quite extensive. So what do we do acutely? Well, the first thing is we need to establish if there is a nerve injury or not. And it is surprising, but half of these injuries will have a nerve component to it. And thankfully, most of them are neuropraxis and recover, but it's quite important to assess them. Of those, half of them involve the axillary nerve, and the rest are mostly musculocutaneous suprascapular. Very rarely the whole plexus will be involved. Once we've documented the nerve status, then we go on to close reduction, which in my case, I prefer to do very gently. There's no need for analgesia or sedation, just very gentle longitudinal traction to try and relax the muscles that are keeping the joint out. If that is not successful, and it does take a long time, it takes 10-15 minutes, and that's a long time when you're pulling on someone's arm. And it should stress that you pull gently, you maintain some tension, you don't really try to wrench the arm out of the socket. If that's not enough, then you can actually do it in a more passive way by letting the arm hang with or without weight, and that usually reduces it. What do we do afterwards? Well, we can immobilize it in a sling. That's a traditional thing. It really doesn't make any difference to final outcome unless you immobilize in external rotation in the position that this gentleman here is demonstrating, and that actually reduces by about 20% the rate of recurrence. However, starting 2 or 3 days after the dislocation and keeping this for 6 weeks is a big ask. And even in Japan, where the study was undertaken, the compliance was quite low. I can't begin to imagine what it would be here in London. Anyway, one of the options acutely is to try and restore the lesion back to its normal anatomical position and do an acute Bankart repair. And now we could talk about the late management. This is needed because there is a rate of recurrence which is age-related. And in the 80s, both Carter-Rowe and Havilius made this connection. And looking at their populations, they realized that the recurrence was not related to the fact that they wore a sling or not, they got back to activity or not, but it was more in line with their age group. And in particular, under 16s have an extremely high rate of recurrence. We still don't understand why, but that's what tends to happen. Bankart was a surgeon in the Middlesex, and he realized that, well, this is something that was known, but he basically advocated the repair of the anatomical lesion, and that anatomical lesion has taken his name, the Bankart lesion. That's a tear of the anterior inferior labrum, and it is relevant because when the labrum in that area tears, it will heal, but it will malunite generally, slightly inferior and slightly medial, allowing the glenohumeral ligaments, in particular middle and inferior glenohumeral ligaments, which are attached to that section of the labrum, to become slightly lax. This in turn allows anterior translation of the humeral head and predisposes the patient to recurrent dislocations. So he proposed restoring the anatomical lesion, which we can see here on MR. And this is a tear purely of the labrum, which is unusual. More commonly, we will have a lesion that involves the capsule as well. In this case, we can see that the capsulolabral complex is distinctly separate from the anterior glenoid. What does that do? As I said, it allows anterior translation of the humeral head. So when you put the arm in abduction and external rotation, that translates the head anteriorly, and it causes on the patient a feeling of apprehension. He might not say anything, but you can actually feel the pec muscles contract, and they generally tend to get quite anxious. That if you place a hand in the anterior part of the shoulder and push back, that relocates the humeral head, and then that feeling of apprehension disappears. This is the basis for the apprehension relocation test, and this is really what is going to tell me if a patient would benefit from surgery or not. You can do all the scans in the world, but at the end of the day, it's the fact that they've got apprehension that will tell you, and a positive relocation test that will tell you they've got recurrent instability. So how do you deal with it? Well, Bankart described a repair of the labrum. It was an open repair. It was described in 1923 after all. And that's how I was initially trained. And then in the late 90s, in the 90s and late 90s, we started doing arthroscopic repairs. And that was brilliant because we could actually see the lesion very well. If we look from the back of the shoulder, we can see the glenoid on this side and the torn labrum, which we then can finish releasing and reattach with anchors to the front of the glenoid. And that we thought was going to sort out the problem. But then 10 years later, in the 2000s, we started getting lots of reports of high level of recurrence. And again, statistics were put at work, and we figured out, particularly this paper from Burkhardt and De Beer in 2003, that demonstrated that if there was a bony defect, whether it was in the glenoid or the humeral head, then the rate of recurrence was extremely high. And you can see here 67% in those cases, compared to 4% if there was no bony defect. So if we take the analogy of the shoulder being like a golf ball on a tee, you can see why, if there is loss of the glenoid or of the humeral head, how there will be a problem. And this is what you get with a bony Bankart or with an engaging Hill-Sachs. The concept of an engaging Hill-Sachs, the Hill-Sachs lesion happens when the shoulder dislocates anterior. You can see how this glenoid has left a perfect imprint in the humeral head. And if, as the patient external rotates, that edge can reach the front, and that's what we call an engaging Hill-Sachs. In those cases, I mean, that's also been described more accurately with a glenoid track, and there's a complex mathematical formula that you can follow to calculate it. But at the end of the day, it is a clinical issue. And since it was a bony problem and we had a very successful bony operation, then all these cases had a Latarjet procedure, which is a coracoid transfer to the anterior glenoid. The problem with that, actually, it's a good operation. It increases the bone stock of the glenoid. It creates, the capsule is repaired, and then it creates a sling that in abduction and external rotation, it sits in front of the humeral head and stops it moving. But it has issues. Mostly, it's a big operation that changes the anatomy. And it was done with screws, which actually tend to be a large part of the problem. So what are the alternatives? As time has gone on, we've realized that not every bony operation needs a Latarjet, and there are certain circumstances where we can do other things. And for glenoid deficiency specifically, Eden Hibinet described bone graft to the front of the glenoid to restore the bone stock there. And it worked okay, but once we started doing it arthroscopically, then we were able to repair the capsule at the end of the procedure. And that increased the proprioception and also the soft tissue stability, which meant that it is now a very successful operation when you have isolated glenoid deficiency. You can see here how the bone becomes, you can restore that bony defect, and then you can do a repair on top of that. And essentially, it's a bony, it's a Bankart repair over a bony augmentation. If you've got an isolated Hill-Sachs and the glenoid is intact, then if the defect is not very big and you suspect that it will be clinically significant, then we can actually try and limit the range of motion. So basically, it's a tenodesis of the infraspinatus tendon. You insert the infraspinatus tendon in the Hill-Sachs defect. The Hill-Sachs defect is posterolateral, and you can actually almost like do a cuff repair into it, and that will limit slightly the movement and avoid the dislocation. Generally, in overhead athletes, it's not a good option because it will change the range of motion, but for someone that's not very active, it's a good one. If the defect is more than 25% of the width of the head, then it's better to do a bone graft and replace the bone. That's a big operation. It requires a posterior approach, and it's not something that thankfully we see often and therefore don't do often. Thankfully, most engaging Hill sacs happen in the context of a bipolar lesion, where not only there's a Hill sacs, but also anterior glenoid deficiency. That makes it much easier for the Hill sacs to engage anteriorly. This is best addressed by increasing the bone stock of the glenoid, by putting a bone block, and then doing a soft tissue repair, which restores the tension of the anterior capsule. And that stops the Hill sacs lesion engaging. We don't have to address it specifically. So what we, in summary, basically, if we have an isolated soft tissue lesion, and this is pretty much 50% of cases in my practice, then a Bankard repair is the only thing they need. If there is bone deficiency and it's localized only in the glenoid, then a bone block as well as Bankard repair will sort out the problem. It basically, doing a bone block converts the combined problem into a purely soft tissue problem once the bone is sorted out. With an engaging Hill sacs, if the glenoid is intact, which is not very common, and the lesion is small, a remplissage as well as a Bankard repair will help. If the lesion is very large, then a humeral head allograft can be done. Most will be bipolar lesions where the glenoid and the Hill sacs are both affected. Then a bone block, and if the Hill sacs is still quite big, maybe adding a remplissage would be the way to do it. Of course, also doing a soft tissue repair. And that concludes my lecture on traumatic instability. I'll leave you with my colleagues to talk about the other sections. Thank you very much.
Thank you very much, Carlos, for the first talk of the evening. A quick reminder to everybody that we've got a questions box on the right-hand side, so please place those in there so that we can chat later on and have a really interactive Q&A. So we're going to move on now to our next speaker, which is Mr. Henry Colaco. Henry is a consultant orthopedic surgeon who specializes in reconstructive and sports shoulder and elbow surgery and complex upper limb trauma. He is the clinical lead for the upper limb surgery at the Hampshire Hospitals NHS Foundation Trust and is a founding member of the shoulder practice and the London Shoulder Meeting. Henry has experience of managing high-profile individuals in a range of fields from professional sport all the way through to the performing arts, and has a keen interest in developing novel techniques of reconstructive arthroscopic surgery, including the management of bone loss in shoulder instability, strategies for irreparable rotator cuff tears, and bicep tendon injuries. Over to you, Henry.
Paul, thank you very much for the introduction. And because we know that Simon's got a big talk coming up next, I'm going to try and keep this brief. So whistle-stop tour through traumatic posterior instability. Hopefully, if I click on this, we go to the next slide. So posterior instability is much less common than anterior instability, as in Carlos's talk. It makes up 2 to 12% of overall instability, and it's about 20 times less common than anterior shoulder instability. However, it may be that the incidence was always a little higher than that, but we're just better at picking it up now. Or maybe we're better at picking it up because we have more options and we have more solutions of what you can do. So it's increasingly common in overhead athletes and patients who do weight training, kind of body weight exercises, high intensity interval training, CrossFit, Tabata, and other similar sports. It again represents a spectrum from traumatic posterior dislocation, which is commonly associated with a seizure from either electrocution or most commonly from epilepsy. There are atraumatic causes. We're not really going to talk about that. We're going to leave that for Simon's talk. But the most common and what makes up the bulk of the patients that we see in clinic is this repetitive microtrauma. And it's repetitive microtrauma leading to microinstability. So not always frank subluxation, not always a dislocation. It's a very different sort of pathology and pathological spectrum to anterior instability. So the clinical presentation, it can actually be pretty non-specific and the symptoms can be subtle. They can present with some symptoms of subluxation. They can have apprehension, but they commonly present with weakness, and they present with cuff symptoms, cuff weakness, and pain. And that can sometimes be deep-seated posterior pain, and it can be localized, but it's not always that common. And they can often present with cuff symptoms, which can be true cuff symptoms, but it's due to overload and abnormal forces going through the cuff as they're trying to chase the humeral head and stabilize it using their cuff, because they have a traumatic lesion leading to the posterior instability. Athletes, particularly overhead athletes, athletes who do overhead weight-bearing exercises and shoulder weight-bearing exercises, describe fatigue. So with repetitive overhead activity, they present with fatigue and a gradual loss of strength. They can also have some mechanical symptoms at times, describing a clicking or a popping, but this is not universal. So clinical examination, where you go through your normal clinical examination, have a look at the range of movement, assess the rotator cuff, as that's commonly affected. And then there are a few specific tests. So O'Brien's test, which has been described as very sensitive and specific for a range of pathologies. It's actually very, very useful, and it can pick up posterior instability. And in some sense, it's a reinterpretation of that test. So O'Brien's test is one very useful screening test. And then the more specific tests, looking at actually placing load on that posterior labrum and directing the force posteriorly with the humeral head, are the Kim test, the jerk test, and also the load and shift test, which is the same as the anterior load and shift test, where you're taking the humeral head, you are loading it onto the glenoid, and then just directing the anterior and posterior force. That's also a useful test to do under anesthetic when the patient is asleep at the time of operation. So if we look at the pathoanatomy, the structures that we're talking about for posterior instability are the posterior labrum, which is represented by the red arc, and that can extend up into the anchor of the biceps, into a slap tear, and it can even extend all the way around the front into a tear involving the anterior labrum or a panlabral tear. Blue section there, if you get a bit of bone loss, you can have almost like a reverse bony Bankart lesion. The Kim lesion refers to what is described as a hidden lesion, so a posterior inferior labral tear. The green line represents that posterior band of the inferior glenohumeral ligament, and it's commonly the anterior inferior glenohumeral ligament that we are familiar with, that we use to read tension and improve the biomechanics and proprioception in the front of the shoulder for anterior instability. But the posterior inferior glenohumeral ligament performs a similar role in the posterior shoulder. Again, you can have capsular labral injuries and capsular labral tears, as well as constitutional laxity and capacious posterior capsule as well. So the investigations that are useful are to look at the bones and to look at the soft tissue. So essentially looking at the bones, we use X-rays and CT scans. This can be useful if you've had a true traumatic dislocation, or at least a specific isolated traumatic instability episode. And other investigations, plain MRI scans, MR arthrogram, again, that can increase the sensitivity slightly. It can be useful for looking at labral tears, particularly if they're not very displaced. And also an examination, not under a general anesthetic, but under local anesthetic. So a patient will have an ultrasound-guided injection of local anesthetic into the glenohumeral joint, followed by examining the shoulder and repeating your same examination, looking at the cuff, looking at the stability, but after injection of local anesthetic, to see what that does to the symptoms, because it can often change it quite dramatically. So just considering true traumatic dislocations, when we look at X-rays, we look at CT scans, and this axial slice on the CT shows the same shoulder as in the X-ray there, and that demonstrates that nice reverse Hill-Sachs lesion with a big chunk out of the anterior humeral head. So operative management of these is a version of the McLaughlin procedure, or a near modification, and that's essentially taking your subscapularis from the front through an anterior approach, through a deltopectoral approach, and advancing that into the bony defect. That has the effect of reducing the internal rotation, but also causing some tension as the shoulder goes backwards, and it reduces the risk of that dislocation due to the lesion engaging with the back of the glenoid. If you have glenoid bone loss, again, in a similar way to anterior shoulder instability, you can address that with glenoid augmentation. Obviously, you can't do a lateral procedure around the back, and so it tends to be using an iliac crest graft, which could either be an autograft or an allograft piece of bone. This is commonly done open through a posterior approach to the shoulder, but again, can be done arthroscopically, although I think it's slightly trickier than the anterior glenoid augmentation arthroscopically. Again, if you've got a huge humeral head lesion, your next stage is actually grafting the humeral head defect. Now, this is in some sense easier than if you have anterior shoulder instability with a large Hill-Sachs lesion, because you can approach it from a more familiar approach from the front of the shoulder. So repetitive microtrauma, these are the common patients that we see in our practice. And you can begin with interventions which are based on physiotherapy to improve the shoulder biomechanics, avoiding the triggers, altering how they do some of their exercises and sport-specific activities. And to just illustrate this, I'm going to bring up a couple of cases. So there's a 32-year-old male. He's recently gone into CrossFit training, and he's been doing a lot of shoulder exercises, including Olympic ring exercises. And he presents with shoulder pain, loss of range of movement, and a loss of strength. Pain score is 9 out of 10. Stanmore percentage from normal score, which is an overall assessment of a percentage of a normal shoulder. So he feels his overall function is only 30% of normal. Oxford shoulder score is 32 out of 48, and he gets night pain. He recalls one specific injury 10 years previously when playing rugby, but since that time, it has been fine until he's taken up CrossFit. So the range of movement on examination, 170 degrees of flexion, 170 degrees of abduction, but with a scapulothoracic dysrhythmia, 40 degrees external rotation, which is slightly less than the other side, but with pain at end of range, and internal rotation to T8. You have weak supraspinatus, O'Brien's positive, Kim test positive, and a positive posterior load and shift test. His MR arthrogram, this is his right shoulder, so this red arrow is pointing to that labral tear in the posterior aspect of the glenoid. There is actually also a small cartilaginous loose body floating around the joint. So we manage this with arthroscopic labral repair. So this is a view looking down at the posterior labrum over there, and there's the humeral head. You can see there's a bit of scuffing on the humeral head. You can just see the top of that bit of fraying in the labrum and a bit of synovitis around the back. So as we look down a little bit further down and actually just stick an instrument in there to elevate it, the whole of the labrum separates very easily, and there's actually an exposed area of bone. So we manage this by trimming away the unstable cartilage, bit of microfracture, mobilizing the labrum. And that's a microfracture pick, just to encourage a bit of clot formation, to encourage a bit of fibrocartilage to fill in the defect. And then ultimately we used two knotless biocomposite anchors and sutures around that capsular labral complex to advance that forwards into the defect. He did very well. 3 months post-operatively, he's back to doing some training in the gym, and his Oxford shoulder score was 44. Case 2. So a bit more of an interesting chap. This is a 37-year-old male. He does judo and Brazilian jiu-jitsu, and he works in IT. So there's a lot of floor grappling holds and submission holds, and he had been caught in an awkward shoulder lock by an opponent. When he presented, his pain could reach 10 out of 10 in severity. He felt his function was only 20% of normal, and he had significant night pain. Of note, he had some previous C6 radiculopathy on that same side, but his symptoms were generally well managed. Range of movement on examination was 110 degrees of forward flexion actively, 160 passively, 120 degrees of abduction, 40 degrees external rotation, and internal rotation T11, both which were equal to the contralateral side. He had weak supraspinatus. Gerber's lift-off test was positive. He had tenderness over the long-headed biceps in the groove. O'Brien's test was positive, and Kim's test was positive. So his MRI scan looked a little different. This was an MRI scan that had been performed before I'd seen him as a patient. But what it demonstrates is the significant glenoid dysplasia. And to compensate for that significant glenoid dysplasia, where he has this dysplastic glenoid with a sort of absent posterior glenoid, is this huge hypertrophied labrum. And having this huge hypertrophied labrum predisposes you to having an injury to it. You can just see that there is actually a little fissure there going into that top of the labrum there at the root of the biceps anchor on the other image, although it's not an arthrographic image. So at the time of operation, this is looking around his right shoulder. It's in a beach chair position, looking from the back, and the probe is just there at the top of the glenoid, at the anchor of the biceps. So you can see there's a little bit of fraying, but as soon as you put a probe in there and elevate it, it all comes away. And then the next view, the one on the right-hand side, we're looking backwards towards that posterior labrum. And you can see this huge labrum, which is elevated up off the articular surface. And again, just putting an instrument in there, and after just trimming the edge, you can see this huge, great labrum, which is formed to compensate for the glenoid dysplasia, is very mobile, and the tail is extending all the way around to the anterior superior labrum. So this one, again, we've just trimmed it, we've prepared the surface, mobilized it, and then this has been secured with 3 knotless all suture anchors into that area there, which is at that interface between that labrum and the normal glenoid articular surface. And the view on the right-hand side is looking from posteriorly, again, just looking at that labrum as it's been advanced into the defect. And that's it. And time's up, so thank you very much.
Thank you very much, Henry, for a fantastic talk. Just a reminder, guys, to feel free to use the chat box and post your questions in there so we can really get into the crux of these things during the Q&A. So on to our third speaker, which is Mr. Simon Lambert. Simon is a consultant orthopedic surgeon at University College Hospital in central London and undertakes complex and revision reconstruction of difficult conditions in the shoulder and elbow. He is also an honorary consultant orthopedic surgeon to the states of Jersey and holds several visiting honorary positions in the hospitals around the UK. He is a corresponding member of the German Trauma and Orthopedic Society, an international member of the Innsbruck Shoulder Society, and a gold member of the AOT Trauma and chairman of the Upper Extremity Expert Group of the AO Technical Commission in Switzerland. So as you can see, he's got a fantastic pedigree. Simon has also published over 100 peer-reviewed research papers, editorials and reviews, and published 20 book chapters. So Simon's going to give us a fantastic talk, and Simon, over to you.
Well, hello. My task is to talk about muscle patterning instability. We talk about patterns of instability, and this slide is deliberately like a Mondrian diagram because like a Mondrian, instability comes in many patterns and diverse presentations, not just the ones that we're most familiar with. Here's an example of a referral letter. I'll leave you some time to just read that. I'd like to come back to that letter a little while later in the presentation to try and tease out what it was that was going on and why the surgeon and the surgery he did were perhaps along the wrong path. Let's put it like that. I think we should agree a definition of the mechanical event of shoulder stability. The shoulder works by the concept of concavity compression, and that's due to the application of a joint reaction force, and many of you will have seen this in previous discussions, that's generated by a rotator cuff working through a surface area or arc of contact that has a capsule and labrum, a mechanoreceptor or proprioceptor mechanism, all subserved through the neurological or nervous system. And each aspect or factor of that equation is slightly different for each of us as individuals and at different ages. So, for instance, everyone, I particularly suspect in this audience, has a rotator cuff. It gets old and can get a little bit worn out and torn in older age, of course, but everyone starts with one. Whereas the surface arc of contact can be a bit variable. Perhaps 10% of us will have anomalies of the glenoid or glenoid labrum, and more is true of the capsule and labrum. For instance, the middle glenohumeral ligament is said to be absent in about 1 in 3 of us. So there are more variants in the soft tissues than in the harder tissues of the shoulder. And the neurological system can be quite readily upset. So all in all, we have a way of describing stability. If that's the case, then instability could be described as a symptom of abnormal movement or position, implying a cortical recognition of a problem that is to do with the mechanics. In other words, there's a cognitive aspect to a neurological process served by a mechanical substrate. And here's that letter again. At the time of surgery, there's generalized multidirectional instability. Well, here we go. If instability is a symptom and the patient is generally anesthetized, then the looseness of the shoulder is not strictly instability, it's laxity, as demonstrated by a positive drive-through sign. But the non sequitur is the therefore. This patient had multidirectional laxity, and that doesn't, in a sense, permit one to do a capsular surgery unless we have knowledge about what is actually symptomatic. And this is the patient's history, the patient's version of all of this. And you can see that the patient started to experience different things in their shoulder as a result of surgery. So there's something missing. Here's that joint reaction force equation again. We can see, broadly speaking, there are structural and maybe neurological or non-structural components. That's a very gross simplification of the system, as I'm sure you will appreciate. But these can be damaged and therefore discontinuous, or they can be underdeveloped or dysplastic. And we can see then that we can start to deconstruct this in terms of trauma and not trauma. And we can bring those together in the sort of neurological sense as disorders of the peripheral or central nervous system. And as a result of disbalance in those systems, we might see emerging abnormality of muscular activation or aberrant patterning, as we called it a couple of decades ago. But if we put all that together, we can see that the structural components of the shoulder can be discontinuous, perhaps due to trauma or degeneration, or they can be dysplastic due to non-traumatic or even congenital reasons. But you can then, for each individual patient, describe a diagnosis of instability as a bit of trauma, a bit of non-trauma, and a bit of aberrant muscle patterning. Now, you might have no aberrant muscle patterning and a completely pre-traumatic normal capsule, in which case your diagnosis is entirely that of traumatic instability. But I would suggest to you that this idea of the Stanmore triangle began the dialogue that we can talk about in terms of classification and cast minds on what we actually meant by the diagnosis of instability. And we'll talk about that in relation to muscle patterning. So the concept was that we had at each pole traumatic lesions, atraumatic lesions, and then muscle patterning, which was a gross overarching term for everything that we could not explain through trauma or atraumatic structural means. And we had this concept that, or rather, I beg your pardon, Ian Bailey and his colleagues at the time had this concept of the polar groups, where you could see almost pure diagnoses, in the case here of trauma, and interpolar groups, where on that axis from trauma to atraumatic structural, you could demonstrate increasing structural abnormality. So as a result of trauma, and we then have, taking this step further, and then there you go, a group of patients in whom the apparent relevance of abnormal muscular activity becomes important. This is the polar 3 group. Now, you'll recognize that 1-2 classification as the Matson classification. That's not new to you, and it will have been discussed. And there are very clear definitions of the group 1 and of the group 2. Atraumatic structural instability, and this business of repetitive microtrauma is often used as the example or the explanation for atraumatic structural. I think that's debatable, but we can come back to that in questions if necessary. But here's something else. This is a group of patients who had normal shoulders at arthroscopy, no evidence of abnormalities of structure. They had EMG anomalies, which I'll discuss in a minute, but they also had demonstrable dislocations, which might or might not be voluntary. They might actively be able to dislocate their shoulders, and they might actually not be able to stop the shoulder dislocating. And the question then arises in most orthodox minds, is this a voluntary or habitual, let's say, feature? Are these patients actively gaining something from the displacement? Well, most times this is quite uncomfortable, and most patients do not seek pain. And so we were able to draw on Ian Bailey's work with Dr. Karen Fisher, a clinical psychologist at Stanmore, who proved that these patients were no more, let's say, abnormal in their mental health and approach to mental health than those in the general orthopedic population, which is a slightly barbed observation in the sense that the normal general population is different from the orthopedic population in terms of response to pain, but that's another story. Anyway, these patients had no history of injury, no apparent structural damage to the articular surfaces. There was clearly something going on with the capsule, and you could see abnormal muscle activation. And it changed over time. So the Stanmore triangle became the Stanmore Toblerone, although that never really caught on. It's just an illustration that the diagnosis of a patient within at time point 1 may change over time, so the diagnosis changes with time. Here's that equation again, now expressed in terms of the Stanmore triangle or its polar groups. You could have instability described as a combination of all of those factors, with patient factors and changing time as something to consider. We did a very big study published by Alex Malone and Ali Noorani and colleagues of a huge number of patients that were seen through the Stanmore shoulder unit in the early 2000s. there were something in the order of just over 1,000 cases for analysis. That was a very big database. And in the whole cohort, we discovered, this is of instability, a mean age of presentation, as you see, that ladies and men were represented roughly 40-60, and the dominant side was in 60% of cases overall, but even left-handers had most of their dislocations on the non-dominant side. And here was the predominant direction of instability. We saw quite a number of patients with posterior instability, quite a number with inferior instability, and quite a number with multidirectional instability. And you see in that graph the prevalence of the diagnosis of trauma, atraumatic structural, and muscle patterning. And you can see, therefore, in the patients with posterior, inferior, and multidirectional instability, that muscle patterning was a very dominant feature, as described by EMG anomalies. And we can see that there was a sort of triphasic distribution in terms of age, with a young age followed by slightly older peaks going into early and mid-adulthood. That's the whole cohort. But if we looked at muscle patterning instability, there was again a triphasic distribution, but much, much, much younger, so that we saw a group in their very early adolescence, a group in late adolescence and early adulthood, and then something in the early 20s. And that was a very important distinction of these patients from the whole cohort. So we had basically three groups. Were these then three different diseases? And it's not, let's say, difficult to understand that these probably are. The very youngest patients were youngsters with not uncommonly dyspraxias or dysaprosodias or some form of very mild cerebral palsy, with hemiparesis that was so subtle it was very difficult to pick up, but you could see it on repeated testing. And then there was the young adult group, largely young ladies, and we'll come to that, and then a slightly older group in which muscle patterning emerged, particularly after other treatment. So what the general observations were that these were, as we said, young patients, largely male overall, but with specific regard to the second group, largely female, often bilateral and often of insidious onset, with painless dislocations initially, which were easily reduced. And only 30% had a trick or party movement. So the idea that people deliberately did this for fun was put to one side. Half of them presented with pain rather than an obvious dislocation. And most had some form of dislocation interfering with day-to-day life. Cuff strengthening rehabilitation did not change all patients with abnormal muscle patterning, but did change many. And I think that's a very important observation. We are at risk of saying that muscle patterning does not respond to strengthening the rotator cuff. That's actually not the case. And much muscle patterning is a response to a weak or asymmetric cuff activation pattern. And we'll come again to that a little while later. So if we go on from there, we can see what features these patients presented us with in those three age groups. Laxity being fairly prevalent, the female gender, bilaterality, and pain becoming a much more dominant problem as we got older, presumably the result of micro instability in its pain manifestation. Most people had a scapular dysrhythmia, and it was very difficult sometimes to note whether that was a primary problem of the scapula or a response to an intra-articular glenohumeral problem. And most patients could demonstrate that how they dislocated, particularly in the posterior displacement. And again, commensurate with that, we could palpate what we considered to be inappropriate muscular contraction. Now, trying to confirm the painless dislocator as a muscle patterning group is quite difficult, particularly in the group that presented with pain and not recurrent observable instability. And this is a typical EMG output. Now, it's really important to remember that EMGs were done for patients with accessible muscles, infraspinatus, anterior deltoid, latissimus dorsi, and pectoralis major, usually the clavicular head. Now, that doesn't mean to say that other muscles are not implicated in muscle patterning. They clearly are, and you will have seen trapezius dystonia, serratus anterior palsy, and so on and so forth, or suppression, I should say, and so on and so forth. So for me, infraspinatus represents the rotator cuff. For me, latissimus dorsi represents teres major as well. Now, the implication of that statement is that we're looking here at gross motor aberrant patterning as opposed to specific muscular aberrant patterning. And that's a point of debate even now between myself and colleagues, particularly at Stanmore. But we can start to pick out what direction the patient's instability and its relationship to inappropriate muscle activity was. So here we see the directions of instability and how much implication there was with respect to muscle patterning. So inferior instability, which the Japanese describe as a tipping of the scapula down, so dumping the humeral head out, was actually all patients demonstrated aberrant activity, in this case in latissimus dorsi. We'll come to that again, and so on and so forth. By muscle, we could see that pectoralis major was implicated in anterior instability as much as in posterior instability. Latissimus dorsi more so in posterior, anterior deltoid likewise, and in those cases in which we could not record activity in infraspinatus, posterior instability appeared to be much more prevalent. There you are, an example of rotator cuff suppression or inactivation or inappropriate inactivity on the background of normal activity in the muscle prime movers. Now, if you looked at the number of muscles involved with each of these diagnoses, you could see that, for instance, with the inferior group, that all four muscle groups were implicated with infraspinatus suppression and latissimus dorsi activation as a couple, which promoted that displacement. But if you look at the overall muscle patterns involved, they are absolutely enormous, and we'll see that in this next graph. There you are. So there are a great number of combinations, but you can start to pick out basic patterns in these combinations of muscles involved with the displacements. What does that tell us? It tells us that the neurological control of the shoulder is complicated. We know that. It also means that it is not always easy to pick out the combinations that are involved with muscle patterning. And we have to ask ourselves whether these combinations are primarily causative or primarily protective, or primarily reactive to the displacement? And I think that's the big debate that we need to get into. If we look at how this can be used in clinical practice, it's largely to prevent the wrong diagnosis being made. If we make the diagnosis of muscle patting and rehabilitate people so that they don't, in a sense, have inappropriate surgery, then we might prevent what is a worry, which is that of a proportion of patients who had actually got muscle patting instability with no structural abnormality did have surgery. And unfortunately, many of them, 50% or so, became degenerative. In other words, they developed arthritis. And that's a poor outcome based on a slightly incomplete diagnosis. Whereas, if we recognize that up front and rehabilitated these patients with all manner of biofeedback type programs, then the patients that developed a stable shoulder were roughly 8 out of 10 of the cases that we treated. And that was an improvement. 25% became stable. Now, in my mind, this is a part of the answer, not all the answer, because clearly the patients who are improved but not stable would like to be stable. There's more to it than meets the eye. But if you did surgery and it was the wrong surgery and it didn't stop the patients displacing, then subsequent rehabilitation was likely not to work at all well, i.e. it behoves us to make the diagnosis early. And if you looked at the posterior group, a bigger group, because that was what was referred, we can see that rehabilitation was substantially better in terms of outcome. But if you operated and it wasn't quite the right thing to do, the cure rate was cut by half, i.e. again, we should be trying to make the diagnosis early. What does this mean in terms of multidirectional instability? Remember that instability is not a diagnosis, it's a symptom. The diagnosis is what is the structural, non-structural, and neuromuscular substrate to that symptom. Multidirectional instability is symptomatic instability in 2 or more directions. It's not, therefore, due to one pathology alone. Each direction could have trauma, atrauma, and muscle patterning elements. So we can come up with a Stanmore triangle, if you like, where there's a single diagnosis in 2 or more directions, and we see the numbers there. Okay, so more importantly, we can see that in the same shoulder, in each of the directions of instability, we can have different pathomechanics. And so if we look at the Stanmore triangle again, we can now define patients as having in one direction, let's say, a type 1-2, and in another direction, a type 2-3 form of condition. And that then allows us to treat each component of the instability appropriately. Does that feel complicated? Well, yes, it does, but that's the nature of instability of the shoulder. It's not simply a sort of simple equation of cause and effect. So thinking about that patient's history and going back to that history, this patient kept mentioning shoulder pain, and over a matter of months began to notice the shoulder was going in and out on movement. He did exercises to hold the shoulder in place, and these were painful and didn't work. So I did an open capsular shift. Now, I think after this short presentation, you'll see that that cause and effect simply didn't follow. This patient clearly had some element of neurological dysfunction in the shoulder before his trauma, So he was a type, let's say 2-3, had a trauma, so migrated to 2-3/1, and the surgeon treated the 1, but didn't quite appreciate the 2-3 bit beforehand. So what does that tell us about muscle patterning instability? Well, it's there. It's not entirely clear, what it means still. In this case, here's the patient's examination, just to put the point that in his contralateral normal shoulder, the findings were the same at arthroscopy as on the so-called dislocated side, or the dislocated side. And that's an important observation, that diagnostic arthroscopy has a role in understanding the etiology of instability. So what's going on? Something provoked the type 3 instability. Surgery for the type 2-1 problem didn't help, didn't make it worse, but there is a neurological problem. What is going on? We still don't know how to really diagnose that. So for me, muscle patterning is important, it's relevant, and it's present. But we have to understand it a bit better than we have to date. And I don't think embracing all these cases as a type 3 muscle patterner is specifically very helpful. Because muscle patterning can be an appropriate response as a protective mechanism in a shoulder that is unstable. And you see here an example of an appropriate protective muscle patterning. It can also be inappropriate, where it's, in a sense, making up for, dealing with, or adapting to a capsular insufficiency, that is, a proprioceptive defect, whether it's acquired or congenital. Muscle patterning can be reactive. For instance, the pectoralis major contraction during an apprehension test, which is what you're inducing a muscle patterning activity, almost to prove anterior instability. Think about that. That is truly a illogical statement. Aberrant activation of the pectoralis major in response to a provocation of the shoulder, which has a capsular labral defect, is a neurological response to the pain and the anxiety of the potential dislocation, and so on and so forth. Well, in summary, I think that we do appreciate the role and importance of neuromuscular perturbation in this symptom of instability. That's a given. But it's also important that we appreciate the importance of analysis and the relevance of neurological perturbation in the generation of what's so-called microinstability, this transition between normal and abnormal is a neurological phenomenon of perhaps modest denervation of parts of the capsule or rotator cuff or muscles in the form of muscle spindles. Think about this. Muscle spindles exist at the neuromuscular junction of muscles, and that's where we get fatty degeneration in aging tissues. If fatty degeneration means that the function of muscle spindles deteriorates in time, then the proprioceptive feedback from the rotator cuff as we age becomes less, and it's more dependent, therefore, on proprioception from the capsule and labrum, both of which are also degenerating with time. So that the instability lesion of a rotator cuff tear, which is effectively a capsular lesion laterally, becomes a proprioceptive defect in the shoulder, which is why it requires some weeks and months to restore stability in a mechanically competent shoulder as rehabilitation improves the neurological adaptability in central terms. And in that sense, the rehabilitation of instability is most definitely a neurological rehabilitation. We know that the timeline over which people improve after stability surgery is that of a re-innervating capsule and labrum. It then needs reintegration into normal movement patterns. So muscle patterning is a normal part of shoulder activity. When it becomes aberrant, it becomes unhelpful. But when it is appropriate, it can be rehabilitated in the normal way. I hope that's provided a basis for a good discussion, and hope that that's been of some interest. Thanks very much indeed for listening.
Thank you very much, Simon, for a fantastic talk, great information, and lots of takeaways. Our final speaker for this evening is Gus Morrison. Gus is a senior physiotherapist at the Institute of Sport, Exercise and Health, where he treats both elite and amateur athletes. Gus has completed a master's degree in sport and exercise medicine at University College London and is an accredited strength and conditioning coach with the UK Strength and Conditioning Association. So he's therefore well placed to help individuals recover both from injury, but also to enhance and return them to performance in their chosen activity. Gus has also pioneered the development of the shoulder assessment unit, which we have here at the Institute. Really looking forward to this presentation. Gus, over to you.
I've been asked to discuss shoulder instability, particularly around conservative management and rehabilitation. So for the purposes of this webinar, I'm primarily going to focus on type 1 instability and particularly into an anterior direction. So joint stability can be expressed as an equation where the joint reaction force or the stability of the shoulder is down to the rotator cuff, the surface area of contact, the capsulolabral proprioceptive mechanism, and the neuromuscular system. So the point here is that we can split the components of shoulder stability into two main buckets, broadly labeled as form and function. Form being the anatomical and mechanical components, so the rotator cuff and the surface area of contact, and the functional or active components being the capsulolabral proprioceptive mechanism and the neuromuscular system. So this concept has been well described by the functional stability paradigm, which incorporates the interaction between the passive and the active restraints, where decreased proprioception leads to decreased neuromuscular control, which complicates the problems of functional instability. Another variation of this hypothesis, which is expressed here, is the functional stability paradigm, or the functional stability threshold of the glenohumeral joint. And it is the total level of functional stability is a combination of the mechanical restraints and the neuromuscular feedback mechanisms. And as long as that combination operates above a critical threshold, the shoulder will operate without problems. Should this combination drop below the critical threshold, the combination is likely to increase the risk of injury. So in relation to the graph, the functional stability threshold is shown by the black dotted line. Below the line is an area in which the potential for injury is increased, and that can be for a few reasons. It can be due to damage to the mechanical components of the shoulder, which are labelled in black, and that would be things such as labral tears, Bankart or Hill-Sachs lesions, or ligamentous damage. And it can also be due to decreased performance of the neuromuscular system, or a combination of those 2 points. And this theory offers some explanation as to why athletes are able to perform at a high level despite mechanical changes or anatomical changes on imaging. And it's because the neuromuscular system is essentially able to compensate for the mechanical changes that have occurred. So when it comes to conservative management, it is only the neuromuscular components of shoulder functional stability that we can realistically hope to increase. To increase stability via changing the mechanical or passive components of the shoulder, we are reliant on surgical colleagues. So in terms of the neuromuscular components of stability, of the shoulder, or really any other joint, they can broadly be split into these three components of mobility, strength, and coordination. So mobility refers to the athlete's ability to access optimal positions for their activity and allow forces to be dissipated over a large number of structures rather than localized to a small number of structures. Strength refers to any element of force production, which ranges from the ability to sustain low force for prolonged periods through to producing high-level force at high velocities. And then finally, coordination refers to the ability of sequencing movements to produce force at the right time, in the right place, and at the right speed. And within this context, it also refers to control or proprioception. So the aim of rehabilitation should be to identify deficiencies within these three components, introduce strategies to correct them, and then retest before correlating this with the patient's symptoms. And in essence, it is a basic scientific process. Form a hypothesis, aim to disprove it, and adjust that hypothesis accordingly. So going forward, I've basically given brief examples of each component in mobility, strength, coordination as a test-retest process. So for example, with mobility, we know that high shear forces occur across the glenohumeral joint where there's a disconnect between thorax and the humerus. So this is essentially when the arm is horizontally abducted when the chest is facing forward. So reaching in a backwards motion. And if the patient is able to maintain that connection between the thorax and the humerus, then less horizontal abduction has to occur, as they're able to coordinate the movement of the hip and the thoracic spine while horizontally abducting the arm with it. So for this reason, it's important to check that the patient has sufficient mobility with structures other than just at the shoulder girdle. And in the image here, this is an example of a lumbar locks rotation test, which is a valid and reliable method to measure thoracic rotation and can be done with an inclinometer or app-based inclinometer. So if we have tested thoracic rotation and deemed the patient to have insufficient mobility at their thoracic spine to maintain that connection between the thorax and the humerus, we can implement interventions to facilitate the adaptation of improved thoracic rotation. It is unlikely that there is one specific intervention that is superior to another, and to be honest, it doesn't really matter how you get there. If you facilitate the patient to improve their thoracic mobility, then you have done what you set out to do, and that's essentially the principle of specificity, where you get a specific adaptation to an imposed demand. Once you've done this, it's important to retest in order to establish you are making progress and able to see if the demand or the exercise or the intervention is appropriate for the patient, and be able to check off these times or these criteria-driven goals as you progress through this process. So the second component is essentially looking at strength. So similar to mobility, there are multiple elements to force production, but for brevity, I have to focus on the peak force of the rotator cuff. I'm measuring that here using a handheld dynamometer, and this is important because the rotator cuff acts to physically pull the humeral head onto the glenoid and keep it there as we move. This essentially facilitates a large surface area of contact and therefore improved joint stability. The obvious question here is how strong is strong enough? And we use research done by Anne Cools, who looked at normative values of rotator cuff strength in healthy overhead athletes. We can then base predicted strength scores of body weight and gender to compare patients to healthy populations and cohorts that are relatively specific to them. Again, the method you use to increase peak force doesn't really matter as long as that adaptation does occur. For stable shoulders in active individuals, low threshold activation exercises that focus on movement patterns, coordination, and sequencing are simply not enough to protect the joint under high forces, high loads, and high speeds. force closure is a critical component of stability. And often heavy loading won't be possible early in the rehab process, but the rehab program should be progressively overloaded in order to eventually expose the shoulder to higher forces at higher velocities. And there are alternatives if this remains problematic going forward. So things like cross-training the uninjured side and blood flow restriction training can be used earlier on to get those adaptations. Again, we come back to that retest principle, and it's worth noting that changes in peak force are unlikely to occur much before 4 weeks, while changes to muscle size and pronation angle will take a minimum of 8 weeks to occur. And we use these timelines to organize and plan testing at relevant time points in the rehab process. The final component of that triangle was coordination. So we know that athletically active individuals who have chronic traumatic anterior shoulder instability have significant deficits in proprioception. So joint position sense in the end range position is reduced following fatiguing tasks. And if the mechanoreceptors are unable to actually accurately report shoulder position in the outer range, then there is a potential for anterior structures to become stressed before any compensatory muscle contraction can take place. So if you don't know if your arm is being dragged back beyond neutral into that kind of action position, your body won't implement a compensatory contraction to prevent it going any further. So joint position sense or proprioception can be enhanced with a combination of open and closed chain exercises. And in this example, the patient rolls from sideline to supine, but maintaining their arm pointing to the ceiling. In other words, they're maintaining the center of mass, which is the weight, over the base of support, which is their shoulder. So if that arm starts to drift away from the center position, the lever length increases, the amount of torque across the shoulder increases, and the weight essentially is perceived as getting heavier, and that provides continuous external feedback to move the arm back to the center. So we test and retest, and the joint position error score can be used to quantify changes in proprioception. So in this test, the tester takes the patient to neutral with the patient's eyes closed. They're then asked to remember that position before returning to the start position, and they need to replicate that position themselves with their eyes closed. Joint position error is calculated, and uninjured individuals are extremely accurate and able to replicate a position within 4 degrees. So the focus of this retest procedure has been around identifying trainable deficits, and it's easy to get caught up in the numbers and focus solely on the scores of strength, mobility, or coordination. And these tests should be used similar to the way that doctors and consultants use imaging. So we're trying to rule things out rather than rule things in. And when we find an issue, we try and solve that problem or intervene. But it's always crucial to correlate the objective changes with how the patient is feeling, as that is the reason they came to see you. So rather than just getting caught up in changes in strength or mobility, it's important to implement methods where you can get a good idea of how they're progressing. I've listed a couple here as the shoulder injury return to sport index. So that is a very similar questionnaire to the ACL return to sport index, and it can be used for athletic participants. The patient-specific functional scale, which can be used on anyone for any joint, and the disabilities of the arm, shoulder, and hand, which is probably a lower level version of but still a shoulder-specific questionnaire, and sport-based questions can be bolted onto that in addition to the basic questionnaire. And any of these can be used to quantify progress, as they're being proven to be valid, reliable tools to do so. So just looking forward to hearing some of your questions.
Thank you very much, Gus, and thank you very much to everybody. I'm sure we'll all agree some fantastic presentations and a real breadth and depth of knowledge provided. So fantastic start, and let's move on to the Q&A. So quite a few questions have been coming through in the chat box. So just going to address generally to the group, and feel free to chip in as you go. But obviously, if anybody feels comfortable and wants to take the lead, then that's fine. So let's start with a general question that came through. So with regards to traumatic instability, and obviously there was a lot of discussion around surgical options. What are the main factors that influence the decision to operate versus trial and conservative management? Anybody want to take that?
I can talk about that. Instability, traumatic instability, once it occurs and it becomes recurrent, it's not something that is going to disappear unless you address the structural component. You can improve it by improving dynamic stability, and that is a big part of the initial management of these conditions. And in many occasions, you can actually get a level of function that is sufficient to live with without actually having further dislocations, although there is generally a feeling of apprehension. However, if you want to get rid of that instability, if dislocations keep occurring, and if they keep occurring, or there's a level of instability such that there's translation of the humeral head on the glenoid, as Simon discussed, that ends up causing problems down the line in terms of degeneration of the glenohumeral joint, and therefore it would be advisable to restore the stability by restoring the normal anatomy. So in traumatic instability, what you have is an abnormality of the structures that keep the static stability, and also of proprioception by virtue of the capsule being abnormally lax in that position. And restoring both is really what is going to solve the problem. So it's not a question of, do you need to have surgery? It's a question of really, can you live without sorting out the problem? And if you can't, then that would be my view to proceed with surgical treatment. I don't know if you guys agree with that.
Anyone else want to add anything?
Yes, I would briefly completely agree. There was a move to arthroscopic stabilization of first-time dislocators based on colleagues in southern Germany and Austria, Switzerland, for obvious reasons, in the sort of ski areas of Central Europe. And there was a huge debate between them and the Scandinavian group, who said you just don't have to operate on any of them because only a fifth or so will become recurrent, and we believe our grandfather Hovelius in that respect. But there was a middle way. Hovelius's work was about the restoration of proprioception. He didn't say that, but that's what it was. And what I think Andreas Imhoff and others in Central Europe began to do was to restore the neurological, what I call the afferent field of the shoulder capsule and labrum, to its normal position so that rehabilitation could proceed quickly, and that the denervation bit of the shoulder injury wasn't quite so influential in the outcome. So I believe that that first-time dislocators should have an appropriate surgical restoration by someone like Carlos or Henry, not me, because I can't do the arthroscopic bit very well, but not because it's a mechanically sensible thing to do, but because it's a neurological thing to do, using the mechanics to hold the neurological system back into place. And I call for what it's worth, the capsule and labrum, the neurological early warning system of the shoulder, the news of the shoulder. And I think that what Carlos and Henry do with the first-time dislocators is restore the news. Because we know that the labrum isn't strictly fundamentally important to passive stability of the shoulder in cadaveric testing. Ergo, it must have another reason. And I strongly suspect that what actually these chaps are doing beautifully is actually neurological surgery of the shoulder. And I know that I'm teased about that opinion, but I think it actually holds.
Cool. Henry, anything to add?
Yes, just one thing. So in terms of restoring proprioception, I think, as both of you have mentioned, I think that's the key. And what we're not doing is restoring a bumper. You are restoring the normal feeling of a shoulder if we're talking about anterior instability. So that when you put your shoulder into a dodgy, dangerous position, you actually have that normal feedback from the structures in the front of your shoulder. And that can allow you to actually rehabilitate your shoulder normally. There is increasing evidence for arthroscopic soft tissue stabilization of anterior dislocations in athletes, in particular overhead athletes, basketball players, American football, and other overhead athletes. There is not a huge amount of evidence for recreational athletes and others, but I think that evidence will come in time.
Cool, fantastic. There was a specific question for Simon, but everybody else feel free to jump in. The question was asked, how influential are SC joint dysfunction or perhaps a history of clavicle fracture on the development of type 3?
Well, I think it does have a role, and probably has a role in making a joint susceptible to instability, I mean instability symptoms as opposed to dislocation in the atraumatic group as well. But if your clavicle is malunited, and most are if they're not treated surgically, and your AC joint is displaced if it's been damaged, or your sternoclavicular joint is stiff through an arthritic process, then the scapula doesn't move normally. It's not in the right position, doesn't start in the right position, doesn't move through a good pattern or rhythm, and it doesn't end in the right position. And that then determines where the glenoid fossa is and its orientation in three-dimensional space. So there are some people, susceptible people, and Henry showed you a beautiful example of a hypertrophic posterior labrum with a glenoid dysplasia. Those people come at the age of 40, 45 with increasing posterior pain and scapular tilting, which is the antalgic posture, but it promotes the problem. And if you get patients like that to then restore their scapula to a normal position so they can activate infraspinatus, the pain doesn't go away, but the stability is improved. Then you have to deal with the painful problem, which is the labral lesion. So I think that scapular posture, however it is driven, is fundamentally important to the business of stability, particularly for the atraumatics. And you certainly see activation of latissimus dorsi in people with scapular dumping, the glenoid dumping, either as a pre-dumping activation, which is true muscle patterning, or as a response to the displacement, which I see in some people with shoulder replacements. If they've had abnormal muscular activation before the shoulder replacement, they still maintain that pattern because it hasn't been resolved up here first. So I think it matters fundamentally.
Cool. Henry, Carlos, anything to add?
I don't think we can add much to that.
I agree. Fantastic. Okay. Question for Gus. So obviously you outlined a strategy of training targeted deficits and obviously the integration of testing within rehab. In the situation where you identify multiple deficits across the range of parameters that you test, what would your strategy be to kind of start that process?
It would depend on the patient's symptoms, but I would usually start with the intervention that would place the least stress on the joint. In instability, it's a little bit more difficult because even in low intensity exercises like mobility exercises, it might actually be very difficult to get the patient to go into those positions. So I would really take into account where the patient is getting symptoms and what kind of loads are provoking their symptoms, and then start with the training stimulus that's going to place the least amount of stress on the shoulder. That will largely be limiting your testing as well, because you're not going to be able to test things like peak force or rate of force very quickly after surgery. And as previously mentioned, a lot of these patients might be in slings for a period of time after operation or after dislocation. So you will be limited in what you can do. As I get further through the process, it will really be which deficits are biggest, and also the proximity to the joint. So things like rotator cuff function I'd value quite highly early on, whereas the testing lower through the chain I would pay less attention to and come to that later on.
Cool, fantastic. Okay, there was a question asked around shoulder clicking without pain or loss of range of motion, and the question was asked, is that normal? Anybody want to take that one?
If I must, I'll say something about it. My view on that is that we don't understand very well the origin of clicks in joints. And although it is not normal, because a normal joint will not click, in my view, I tend not to worry overtly if they are not clearly symptomatic. If there is a click in the context of a pathology, particularly in instability with labral pathology, then that becomes relevant in the process of diagnosis. But I'm not sure that it's something that I would address directly as a symptom. It's one of the diagnostic features of the problem, and it can be put in context with the rest of the symptoms. I'm not sure we can address them specifically. What do you think, guys?
Well, I was just going to add just a couple of things, really. Some obvious things. Clicks are simply a surface phenomenon. I mean, it's a distortion of tissue. Probably, maybe some gas is involved, but it's a distortion of tissue. And I naively, perhaps, distinguish between monophonic clicks and polyphonic clicks. The monophonic click is what Henry would have probably found on examination of his posteriorly dysplastic glenoid with hypertrophic labrum as the head re-entered during the re-entry phenomenon, a little clock. That may or may not have been painful, but it's a monophonic clock. Whereas if on relocation there was a grind as well, a sound, which is lots of clicks altogether, for me that's the articular surface. So I would say in that case I've got a loose labrum and an articular degeneration, and that helps me to interpret the MRI or an arthroscopy. So although I don't want to make too much of this, I think actually the audible sound is quite informative. Take the upper pole of the scapula, a clonk, 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 clonk of an exostosis or a hooked scapula is very different to the grind of a scapulothoracic dyskinetic movement due to some sort of, I don't know, rhomboid weakness or something like that, or even the posterior instability of the glenohumeral joint driving a scapular dyskinesia. So clicks are informative, but they're not, let's say, they shouldn't be interpreted out of the context of everything else, the stiffness, the instability, and so on and so forth. But I think they're quite interesting to understand. And everybody's laughing now.
Henry, anything to
add? I think that you can often find a click or a clunk, but the patient will tell you, oh, when I do this, it makes a noise and it catches, or they'll tell you what that clunk is. And they'll say, I can feel my biceps just subluxing at the front. And most of the time, how they perceive what that clunk is doing is not actually what it is. But occasionally, as I had last week, that patient absolutely diagnosed his biceps subluxing into his subscap, which he could feel. But that's very uncommon. And so the way that people interpret their own clicks and clunks will reinforce what they think the problem is. And actually, that's really the case.
Brilliant. Okay, and then a general, perhaps topical question. Alan Wynne-Jones appeared to have dislocated his shoulder 3 weeks ago and is hopefully going to captain the Lions. And obviously, from a non-shoulder expert, that would seem a relatively short time frame. So I'll ask a group of shoulder experts: is that a relatively short time frame, and is there any potential indications for that? Open to anybody who wants to take it.
Go on, guys. You're the elite sports people, shoulder surgeons.
This is a question about how much the player is worth to the team and how much this match is worth to that player at that point in his career. It's not so much a question about shoulders. He might get away with it, but it's more about the value of the player to the team and the value of this match to that player in his career. And as Gus will have experience of, professional athletes are a very specific group, and you know, things that we learn from managing professional athletes can definitely influence the way that you can manage recreational athletes. But they are a very specific group and they have different needs and drivers. So he might get away with it.
So this actually brings a much wider subject, which is exactly that, treatment of elite athletes. I have patients that come and say, well, I've read you've treated so-and-so and I want to be treated the same. And I tell them, no, you don't want to be treated the same. The treatment of elite athletes is usually tailored to exactly that, to their activity and their return to function. They don't see beyond that. It's the next match, it's the next competition. If we're treating recreational athletes, what they want is a long career. They don't want to get back to training in 3 weeks. They want to get back to training in 3 months so that they can actually do it for many years. And that's something that is quite important to distinguish in this case.
Fantastic. Simon, Gus, anything to add?
I just guess from a non-surgical perspective, it would really be around, we know there's going to be structural deficits, or likely to be structural deficits around the shoulder that are not going to be changeable before the player returns to play. So in Simon's equation, we know that the shoulder is going to be less stable. And then if you think back to that threshold of what will constitute a stable shoulder, that player is going to be very reliant on the active components around the shoulder. And then it's just prioritizing where are the deficits around there and what can we hope to change within 3 weeks. So it's really going to be neural changes that we're going to be almost entirely reliant on in that timeline, rather than any structural changes to muscle, tendon, etc.
Brilliant. Fantastic. Okay, that's probably a nice point to end. It's past 8 o'clock now, so everybody probably needs to have dinner, get ready for bed. So that just leaves me to thank all of the delegates for registering, and of course to our expert panel of speakers. And I think you'll agree, some hugely insightful presentations and some really good discussion. So hopefully everybody took something from that this evening. Just a quick reminder that this recording will be available on the ICH website in the next few days, and you should, or if you registered, receive a certificate afterwards. And also as well, just a reminder that the ICH are launching a specialist shoulder and elbow clinic, which is due to start in September after the summer break. So anybody with current or potentially in the future shoulder issues, you've obviously heard from the experts today. You can come and see them directly at ICH. And just a final reminder, just for more information, please feel free to follow us on Twitter, which is @EICH. And we're regularly posting information about new webinars and obviously the activities of all of our consultants. So thank you very much and have a fantastic evening.